kids things like, what, did you have lunch yet? What grade, what's your favorite class in school? Who is your teacher? So it's a little bit more specific for children because this can all, again, concussions don't always happen on an athletic field. They can happen at recess. And then the other questions, again, focus on that somatic, physical, emotional, and cognitive disorder that you see when someone has a concussion. And it also adds something called a balance examination. People who have concussions are can be very unstable on their feet. So for the background, they kind of want to see what your baseline mental status is, what your relative cognitive ability, are you a jock, or do you have a head on your shoulders? How do you feel? And this again is the somatic feelings. Are you nauseous? Are you dizzy? Are you having photophobia, phonophobia? And that brings in that aspect. And then the cognitive assessment, they ask questions about gait, orientation, and then the balance examination. And the balance examination, what they use is called the tandem examination, where you have tandem gait testing. So you have the patient stand with their non-dominant foot. So if you're right-handed, you have your left foot in the back and your dominant foot in the front, and then you have them close their eyes. If they bobble more than 5 times, then that's very suspicious of a patient having a concussion. So the athlete has an accident, the coaches do this SCAT assessment test, they determine that they have a concussion, they take them off the field, and now they come to us. What do we do? So basically our 2 choices is when the patient comes in, if they're alert and oriented, is do we need a CAT scan, and then what do we do with these patients? What's our disposition? That's pretty much the job of the ED physician after ABCs. But we assume that these patients, when they come to us, their ABCs are intact. So how do we determine the need for imaging? Basically, the 2 big studies that we use to determine if somebody with traumatic brain injury, mild traumatic brain injury needs a head CT is the New Orleans criteria and the Canadian CT head rules. Again, the Canadians, this is also, I think, Ian Steele's group up in Canada who come up with a lot of our decision rules. And these aren't that helpful, but it's the best we got. Obviously, if I have somebody who comes in with a GCS of less than 15, who's got a suspected open skull fracture, who's got a sign of basilar skull fracture, who's 65 and older, who's very amnestic, I don't need a decision rule to tell me that I'm going to scan these patients. This is not really helpful for the asymptomatic patient who's had a concussion. But again, it's the best we got. And the top 5 things, again, these patients who have these 5 criteria, again, a low GCS, open skull fracture, basilar skull fracture, 2 or more episodes of vomiting, and they're over the age of 65, they have a high risk of neurosurgical deterioration requiring surgery. But again, I don't really need a decision rule to help me with that. But based on those two decision rules, ACEP actually came up with a clinical policy in 2008 to address these questions. Which patient deserves a non-contrast head CT after a mild traumatic brain injury? What's the role of MRI versus non-contrast CT? And who can you discharge? So those are important questions for us. I'm going to dispel the MRI versus non-contrast CT right off the bat. MRI is not helpful, not going to give you more information, and they're going to be much more time-consuming, much more difficult to get. So if you have someone who you suspect is concussion, go for the CT, don't go for the MRI. They did talk about a few biomarkers which might be in the works for concussion, which would be great, but again, none of them are FDA approved or have been panning out so far. So based on those 2 questions, with any guideline, you have to know which patients you can include. So for the ACEP guidelines, you can include anyone who's had non-penetrating head trauma, and they present in less than 24 hours after the injury. So Tom Boonin, who started vomiting 3 days later, he would not fit this guideline, right? Because he's having symptoms more than 24 hours after his presentation. And they have to have a GCS of 14 or 15. Exclusion criteria, penetrating trauma, multi-system trauma, or they're less than 16 years old. So according to ASAP, a head CT is indicated if you had traumatic brain injury with loss of consciousness, so those 10%, if you have headache, vomiting, you're older than 60 years old, intoxicated, you have short-term memory deficits, seizure, focal neurodeficits, or any sign of coagulopathy, or you're on a blood thinner. Hopefully you're not cycling while you're on Coumadin. And this one's the one that's kind of the most helpful for us, because these are the patients that we're going to see, the ones that come in that have, you suspect a concussion, who have post-traumatic amnesia, they don't remember what happened, but they never lost consciousness. And again, this is what our governing body recommends, and it makes sense. You know, if they do have a focal neurodeficit, if they're vomiting, they're elderly, they have signs of fracture, those patients deserve a scan. But other than that, they really are alert and oriented now. They have a normal physical exam. They're not, not above 65. You can probably discharge them without the need for imaging. So we've now decided whether or not to image them. If they have no findings that come up. Yes?
Just as a quick aside, on those criteria, they had level A and level B criteria, and the level A criteria were really almost the same thing as the New Orleans criteria. The level B put in severe headache, and I think part of the reason why is when we look at retrospective studies, they found patients who in the New Orleans criteria and in the Canadian wouldn't have fit in there, but didn't have loss of consciousness and ended up having something. So that's what got the severe headache in there. So it was kind of gave physicians an out to say, well, you know what, they still didn't lose criteria, which usually just takes them out of the whole thing, but if you really wanted to, you could go ahead and get a CT because it's not unreasonable, even though the numbers are really small. So that's what really differentiates, I think, the ASEP ones from either using just the New Orleans or the other one, kind of combine and add that one piece in there. So it gives you a couple different options.
So the question is, if we looked at Tom Boonen with that severe headache, he probably would have deserved to get, based on these rules, deserved a scan instead of going back on his bike a couple days later. So a little bit about discharge planning. So now we've scanned them, we don't find any major injuries that need to be admitted for, and we want to send these patients home. And how do we decide who we send home? I was actually at this race. This is on the Harlem Crit, which is up in Harlem, and the guy on the ground just crossed the finish line and slid on his belly for about 20 feet. Maybe. Yeah, so he just kind of got up. Yeah, a lot of road rash. So basically, the guidelines state that any patient who has an isolated mild traumatic brain injury, who've had a negative head CT, if you choose to get one, are at minimal risk for developing any type of intracranial lesion and therefore may safely be discharged from the ED. So, and that's what we worry about, right? Because we always worry about that, remember that guy that you sent home? Or remember that patient from last night? This answers that question. Are we going to get that phone call or that call from Dr. Legoma and say, oh, remember that guy with the concussion that you sent home last night? Most likely you probably did the right thing. And the other thing, the recommendation, that when you discharge the patients, you have to give them very close discharge instructions and to tell them about the symptoms of post-concussive syndrome, because most likely they're going to have that. So why can we send these patients home? What's the data behind it? So there's two major studies. One was from the Emergency Medical Journal in 2005, where they looked at 62,000 patients with mild traumatic brain injury, all of which had a GCS of 15, and out of those 62,000 patients, only 11 had some type of deterioration. So the chance of you getting that phone call from your administrator are pretty darn low. And that's why we say that patients who have a negative CT scan, if you choose to get one, you can safely discharge them without neurological deterioration. And the other study was actually a prospective study done in Sweden, where they looked at 39 hospitals and 12,000, almost 1,300 patients. Of those 1,300 patients, they had a 6% of positive findings. But no patients with a negative physical exam and CT discharge from the ED required subsequent admission or surgery at 3-month follow-up. So again, if you follow these guidelines, the chances that they have significant deterioration is very, very low. And so you could probably send somebody home with a concussion. You guys know who this is? It's Keenum. So this year, he was in a game, I forget who he was playing, but it was 5 minutes left. And I couldn't pull up the videos, they took it offline, but he was obviously wobbly, confused, but he waved off his coaches, they let him play because it was like the last play of the game, and they let him play. So even with all this talk about concussions in the NFL and how they're still not following their own guidelines. But why do athletes insist on going back in the game? Because a lot of them are symptom-free within 15 minutes. But it's been shown that if you go back to play, you have decreased mental ability, physical ability, again, balance and coordination, and the re-injury rate within the first 10 days of initial injury is 4 to 6 times higher. And that's a big problem because we're going to talk about a serious side effect that could happen, which is called second impact syndrome. And then they also have these repeated concussions. You have that post-concussive encephalopathy. There's been signs of depression, an increased risk of suicidality amongst these players. So these repeated personality changes. So again, you have a higher risk of getting hit again, and the more you go back to playing. So this is really important. So you decide that you can send your patients home. What do you tell them? What do they expect? What's the expected course? And we do this with MBAs all the time, right? You're going to feel worse tomorrow so that they don't come back. You have to tell your patients, the odds are in their favor, 80 to 90% of patients will be symptom-free within 7 to 10 days. Patients who have more severe findings at the time of the impact, so the nausea, the photophobia, they're going to have a much more prolonged recovery course, and children will have a much more prolonged recovery course. So those are your two things that you want to keep in mind. So if they're feeling really lousy, they're going to feel lousy for a much longer period of time than the average patient. So what do we tell them? We have to tell them to look out for these signs of post-concussive syndrome. They get headaches, dizziness, fatigue, irritability. What does it sound like? It sounds like a concussion, right? So it's more of a spectrum. It's just that things aren't getting better. But be expected that you're going to feel like crap for a while. And then you're going to have that noise sensitive, light noise sensitivity. And again, the anxiety, the just feeling really crappy, and it can last for quite a while. So the cornerstone of management at this point, we all have heard about this idea of cognitive rest and physical rest. And so, which we'll talk about, that's pretty much the cornerstone of treatment, is you have to rest the brain. The brain has taken an insult at this point. You need to rest the brain. And then a lot of the athletes, when can I go back on the field? When can I go play? Can they go, as soon as they're symptom-free, can they go all out? No. They have this protocol which is called the graded return to play. And you have to make sure that you have symptom resolution before you can go on to the next step. So this idea of physical and cognitive rest, technically, by the book, you're not supposed to text, you're not supposed to read, you're not supposed to watch TV, you're supposed to sit on your couch and do nothing and rest the brain. First, imagine telling that to a professional athlete whose livelihood depends on whatever sport they play. But even more so, imagine telling that to a 16 or 17-year-old kid. You're going to sit there on the couch, you can't play your video games, you can't watch TV, you can't read. It's really impossible. And there hasn't even really been shown that that's actually beneficial. So the current guidelines are what we call symptom resolution, that it's symptom grade. So if you're able to sit on the couch and read a book and it doesn't cause you a headache or feel nausea, then go read your book. But if the headache comes back, put the book down. You know, you're reading your book, now let me play a little video games, the bright lights on the screen are really bothering me, go back to reading a book, which is probably better anyway. But it's really symptom guided, and as you move on, but this idea of complete cognitive rest is no longer holding true. And then if the athlete wants to go back to playing or doing whatever you do, like say, you have to remember that not all concussions are from MVA, so it might be somebody who's been in a car accident. You want to make sure that you're symptom free before you go on to the next step. Then you can start with light aerobic activities. Usually they say about 48 hours of between each of these steps. Then you can do sport-specific activities, non-contact training drills, and then you have to get full medical clearance before you can do full contact practice. Who gives the medical clearance? Not from the ED. You know, your mom's going to come and say, "Oh, my kid has a football game tomorrow, next week, can they go?" No, you're not to allow them to go back. They have to be seen either by a sports medicine specialist and have them go see Walter, or somebody who, or a neurologist trained in concussion. I believe, Walter, we have a concussion center here now, right, downstage?
So the concussion center basically is me or Christine Prasad. That's pretty much it. But mainly what ends up happening is that she has a clinic downstate on Mondays at 8 a.m. where what she'll do is she'll do a neurocognitive test, which right now is the impact. You can kind of debate the utility of that, but long story short, what she does is kind of just what you said. She takes care of the symptoms. Initially, she doesn't put them on any medications for headaches or anything like that because we don't want to give them rebound headaches. So that's one of the things that they may end up having. And she just does just what you said. She starts them on a graded return to play protocol. Usually it'll take at least a week for them to kind of come back. The biggest important things is that they can't come back to play sports until they can go back into school. So if you can't go to school, then you can't play your sport. And the next thing is that one of the important things is that just giving them notes for school, right? Like no standardized testing, kind of give them a half dose, give them like a halftime school period, lighten homework and things like that, just so their teachers kind of know that they've had a concussion and that it may affect their grades. And like, especially now with all the tests that they have like repeatedly over and over again, it could affect their performance on some of those. But yeah, that's pretty much what Christine will do when we get any of these patients.
And then they can go back to playing. So why do we care? Why do we tell them that they can't go back to playing? It's this idea, this disorder called the second impact syndrome. And this is very, very rare. There's only been about 17 or 19 cases, but they have a 50% mortality and 100% morbidity. And it's basically a concussion, a second concussion that happens during the time that you're still recovering from the first. And so this is a devastating side effect of concussions. It's the second impact syndrome. In 2011, in the Journal of Pediatrics, they took a registry of sudden death in young athletes. Of that, there were a total of 1,800 deaths, 248 of which were due to head and neck trauma. And of those deaths, 148 were football players. So I'm wondering if in the future, like Pop Warner and high school football maybe going away, but at the same time, out in Texas and the Friday Night Lights, it's a big part. It's a big part of the culture. But of those football players, 17 football players died of sudden impact syndrome. And there was one of these very devastating cases, which this is where you guys can come in. One of these football players' first concussion wasn't from playing football. He was in a car accident a week before, had a concussion, but was not diagnosed, went to play football, had a second concussion during the game, and died of second impact syndrome. So that's why I'm harping so much on this, that we have to recognize the concussions when they're not happening on the field, because obviously you don't have a SCAT 3 or something like that when you're out on the field. So, did Tom Boonen learn his lesson? Not really. This is in October of last year. He was at the tour of Abu Dhabi and crashed, and this time he sustained an actual skull fracture. But he's back racing this year. Just last week, 2 weeks ago, was a really big race called Paris-Roubaix, which is really fun to watch because it's along cobblestones in the northern France. almost 200 miles of cobbles, and he came in second, so. But he's probably going to retire next year. So just for review again, just remember what a concussion, it's metabolic, not a structural problem. It does not necessarily involve loss of consciousness. The diagnosis needs to be made by a physician or a neurologist, but the coaches have tools to help them pull the players, and that's called the SCAT-3. The three components are the same thing as the cognitive, the somatic, balance testing, and for those who need head CTs, is anyone who's got a GCS less than 15, who's persistently nauseous, who has a severe headache, and who can you can discharge patients pretty much who have negative imaging studies. So when I first, yes?
Finish it. So I just had a question about time course. So like I had a patient the other day came in like 3 days after her traumatic injury, was still having a lot of symptomology, and we were debating about SCT. And so in terms of when you're applying the SCT rules, what is the end point of time for the time which they would apply?
By the book, the ACEP guidelines say that they have to present within 24 hours of their injury. But then at the same time, if the symptoms aren't progressing or worsening or deteriorating, you could probably might apply it, because then it may just be post-concussive syndrome. But obviously, if they're deteriorating, they're getting new symptoms, then that may be a sign of deterioration, and then I would probably scan them. But by the book, they have to present within 24 hours. Yes?
So there are some new studies that are actually proving that, suggesting that there are structural damages in concussion, and they're usually located in the communication path